Hello, ladies and gentlemen. I'm Dr. Wilfred Lee from A&E Department of Tien Shui Wai Hospital of Hong Kong. Today, it is my honor to be here to share with you our experience on teleconsultation in a district hospital. The topic I'm going to present is a multi-sensor integrated teleconsultation model for critically ill patients to enable timely conjoint resuscitation with intensivists in a district hospital. First of all, let me have a brief introduction of the background. This is Tien Shui Wai Hospital. Tien Shui Wai Hospital is a district hospital located in the northwest part of Hong Kong. I'm now working in the A&E department of this hospital. It started its service in year 2017 and provide only limited service, including A&E department, specialty outpatient department, and some convalescent inpatient services. Patient requiring acute inpatient service would be transferred to nearby regional hospital, Port Oi Hospital, and Tuen Mun Hospital, which is 5 kilometers and 6 kilometers away from Tien Shui Wai Hospital. When we come across critically ill patient in A&E, we have to consult intensivists in Port Oi or Tuen Mun Hospital by phone. Based on the information shared in the phone conversation, the intensivist has to decide if the patient requires further care in ICU or general medical wards. If in doubt, in fact, it is quite common, the patient will be transferred to the A&E department of Tuen Mun or Port Oi Hospital for further assessment by an intensivist. This creates several problems. The patient journey will be lengthened as the patient needs to have A&E stop before arriving at the destination unit. It will increase the infection risk as the patient has to stay in more places and contact with more persons. It also adds extra workload to the A&E department of Tuen Mun and Port Oi Hospital. To deal with this situation, we develop a system to enhance the communication between A&E department of Tien Shui Wai Hospital and ICU of Port Oi Hospital. It is a teleconsultation system integrated with high-resolution video conferencing and various inputs. The pilot started between the A&E of Tien Shui Wai Hospital and ICU of Port Oi Hospital and was implemented on 1st of October, year 2020. A standard operating procedure was strictly followed, including patient selection and patient consent. As this pilot was only for Port Oi ICU, in patients with condition not manageable in Port Oi Hospital, conventional consultation to Tuen Mun Hospital would be used instead. If patient was conscious, verbal consent will be obtained before consultation. Otherwise, the consent will be made by 2 doctors for the best interest of the patient with explanation to the next of kin if available. The consultation was conducted through Zoom. In Tien Shui Wai A&E, we used a console as shown in the picture. It was a computer on wheel system. You can see there is a camera mounted in the front of the console. It is a pan-tilt zoom camera. Through this, the intensivist could see the patient and the vitals shown on the monitors behind the patient. A 4K action camera is also available if high-resolution image is needed. For example, the morphological features of skin and wounds. A small size scanner is also available to share some documents such as electrocardiogram and some hard copies of report brought in by patients. These slides also show us the receiving end in Port Oi ICU, which is simply include a desktop computer. The console can also be connected to ultrasound machine, enabling real-time streaming of ultrasound images. This slide illustrates how A&E doctors share the ultrasound finding with the intensivist. Intensivists can also advise and require different views of scanning as needed. Ideally, the more information the intensivist obtains, the more confidently he can decide the destination of the patient. It is less likely that patient being sent to a second assessment in other A&E. But did we achieve this objective? Let's have a look on the data we collect after implementation. Before implementation, that was in September of year 2020, there were 10 ICU consultations made by Tin Shui Wai Hospital A&E. 9 of them require second assessment either in the A&E of Tin Shui Wai at Tuen Mun Hospital or Port Oi Hospital. In the first 6 months after implementation, there were in total 48 ICU consultations. 27 of which were teleconsultation. 25 of them did not require a second assessment in Port Oi A&E and was directly admitted to the ward or ICU. On the contrary, in those 21 patients using conventional phone consultation, only half of them were directly admitted to the ward, and half of them needed second assessment in Port Oi A&E. In conclusion, the EICU teleconsultation system can make the conjoint resuscitation more timely and accurate. It can also avoid unnecessary stop for second assessment. This prototype can be generalized to other acute care services with time window, such as acute stroke, heart attack, and sepsis. It can also make remote monitoring of patients in district hospital by intensivists of regional hospital feasible and visible. And finally, it may enrich the service spectrum of district hospitals. That's the end of my presentation. I would like to take this opportunity to thank my colleagues for making this EICU idea come true. I welcome comments and questions. This is my contact. Please feel free to email me at any time. Thank you very much.
I'm Jennifer Fang, neonatologist and medical director of Mayo Clinic's Teleneonatology program. Thank you to the conference organizers for inviting me to present and be a part of the 44th World Hospital Congress. I'll be presenting on implementing effective, sustainable acute care telemedicine programs using the neonatal teleresuscitation model. I do have one disclosure, which is that I have licensed IP, earn royalties from, and hold stock in Teladoc Health. So to lead off, I thought it would be important to answer this question. Why should organizations implement acute care telemedicine? So there's a few reasons for that. The first is that digital health is going to be a part of the future of healthcare delivery, and organizations need to think about how they're going to transform healthcare delivery for their patients, including the critically ill patient. Second, telemedicine allows organizations to be more agile and responsive to patient needs, including patients who require resuscitation or critical care. Third, acute care telemedicine programs, like other telehealth programs, allow organizations to expand their reach beyond the walls of their own hospital, really helping patients who may be in need of critical care, but located in a more distant, smaller hospital. So when we think about implementing an acute care telemedicine program, there are really 4 essential features to make the program both effective and sustainable. The first is the program must address a defined patient need or quality gap. Second, it should use an efficient clinical workflow and a high-performing telemedicine platform. Again, this is acute care telemedicine, where these are very emergent situations. Third, the program really needs a foundation of collaborative relationships between the distant and originating site. And then lastly, you must measure program performance so you can communicate the value of the program. And this often includes both process and outcome metrics. If you take all of these into account as you're designing and implementing your program, then your program is much more likely to be adopted into routine practice because it meets a need and it functions well. And that program is also very well positioned for scalability. So I'm going to be using the model of neonatal teleresuscitation. And this is a telemedicine network that allows neonatologists to establish real-time audio-video telemedicine connections with smaller community hospitals so they can assist when a neonate needs resuscitation or critical care. Now, the program at Mayo Clinic has been in place for over 8 years. We've performed over 650 consultations. We serve 19 community hospitals in a 2-state region. And we are available 24/7, 365. It's our neonatologists that staff the program. So let's think about that first essential feature, the need that the program must address a patient need or quality gap. So ideally, this is going to be evidence-based. For our program, there was a wealth of literature demonstrating that high-risk neonates, particularly those who are born preterm, are at higher risk of mortality and serious morbidity. So there was quite a significant outcome disparity in our patient population. Now, in addition to addressing a patient need, the root cause of that need needs to be able to be addressed through telemedicine. And so for us, we felt we could leverage the expertise that's in our NICU to assist those community hospital care teams, because we know that those providers in smaller and more rural hospitals do not frequently use their neonatal resuscitation skills. And evidence shows when you don't use those skills frequently, they decline rapidly in the matter of 2 to 3 months. And so we felt that we could use telemedicine to achieve a more equitable access to neonatologists and resuscitation expertise. And you can see in this map of the United States that shows the distance to a neonatologist, that in the center part of our country, our patients, our pregnant women, our neonates are at quite a distance from a neonatologist. But if we use telemedicine, we can bring that expertise to the bedside when needed. Now, that second feature is that of an efficient clinical workflow and a high-performing telemedicine platform. And again, this reflects the use case we're talking about here, that the design needs to be really informed by these emergency scenarios. So for neonatal resuscitation after a baby is born, assessments and interventions can happen as frequently as every 30 to 60 seconds. And when we were first designing and implementing this program, when we spoke to our colleagues in these smaller hospitals, they readily communicated their need for the rapidity of response. I remember a nurse manager telling me, we just want to push a button and have you there. So in addition to designing for rapid activation, we also need a reliable telemedicine platform that can sustain the connection for the duration of the consult. The connection is never dropped, and the audio quality is excellent without any drops, and the video quality is also very high. So for our program, we expect time to video to be less than 5 minutes. And you can see we achieve a median time to video of just over 4 minutes. The product we use has an uptime of over 99%. And users rate their satisfaction with our program very high, and the audio and video quality very high. You can see 4.5 to 4.6 on a scale of 1 to 5, where 5 is excellent. Now, this third essential feature is collaborative relationships. These are fundamental to the program, that the distant site and the originating site must trust each other. There must be mutual respect. That the idea is that this is a partnership, it's a collaboration. That remote consultant is not coming in to criticize, to judge, or critique. We're really working together to better meet the needs of the patients. Now, we achieve that with our program, through outreach education, we go out annually and do things like skill stations or case reviews. We also participate in simulation with our community hospital sites, where if they're doing NRP training, they'll call us and we'll connect via telemedicine during one of their larger mock codes. And so this gives everyone, again, a chance to practice and interact. We also hold an annual forum where we will review what happened the previous year, what may be coming up for the next year, and it really, again, helps facilitate that sense of community. One other point to consider is communication during the consultation. For our community and rural hospital sites, these situations are often very stressful and anxiety-inducing. And so when that acute care physician comes in, whether it's a neonatologist or a stroke neurologist or an emergency medicine physician, they really need to bring not just their expertise and their experience, but also that calm and supportive manner so they can help that team work well. And we also need to have realistic expectations. These sites are often lesser resourced than what we may be used to working in a tertiary or quaternary center. So we need to have that in our minds as we're guiding and making requests of the team. So lastly, these acute care telemedicine programs must be measured for their performance. You need to identify, measure, and monitor both process and outcome metrics. And you can see I gave examples here. These are often going to fall within the realms of quality, safety, experience, and cost. And we have these for our program as well. Resuscitation quality. We look for safety at the time between our settled birth injury cases. We survey both community hospital physicians as well as neonatologists on their satisfaction with the program to ensure it's performing as it needs to and meeting their needs. And then we look at cost savings, which for us is primarily through being able to avoid unnecessary medical transports and the costs associated with medical transport, as well as days in the NICU. So as program leaders, we need to be able to use these measures to communicate the value to organizational leadership. And as an organizational leader, they really need to also demand that this be communicated to them to hold program leaders accountable to program performance and resource utilization. So with that, I hope in the short time I have prompted you to consider implementing acute care telemedicine to better meet the needs of your patients and expand organizational reach. That successful programs will address an evidence-based quality gap, will be designed for high performance, founded on supportive clinical relationships, and will provide measurable value to both the patients as well as the organization. I think using this approach and this framework, the program should be very effective and sustainable, and organizations can avoid costly implementation errors. With that, I'm happy to answer any questions within the conference app, or please don't hesitate to reach out via email. Thank you.
Dear professors, doctors, ladies and gentlemen, I'm Dr. Kevin Wong from the Department of Surgery Tuen Mun Hospital, which is a regional hospital in Hong Kong, serves about 1.2 million population around that region. Today, I would like to represent my colleagues to share with you a program, Critical Actions for Response and Escalation System. We call it CARES. Here is the background information. Early detection of clinical deterioration is important. There are so many evidence to support the earlier the detection of clinical deterioration, the higher the chance to save a life. And in our center, Modified Early Warning Score, MILS, has been used for around a decade. However, MILS is not well received by our frontline staffs. High bed occupancy rate, lack of continuous training and support, difficulty in measuring respiratory rate, etc. may be some of the reasons why they are not frequently using MILS. Besides, we need a comprehensive escalation plan to make it practical for frontline staff to use. In an internal review of our department mortality cases, Many of these cases deteriorate suddenly and end up in unexpected death, around 8.9% in all of our mortality cases. And that's the reason why we need to carry out an evidence-based program, CARES, in order to provide early detection of clinical deterioration, timeliness and competence of clinical response. We also invited 2 scholars in universities to deal with human factors, making the equipment and medical network interface in this program easy to use. In this program, we adopted National Early Warning Score 2 developed by the Royal College of Physicians in UK as the early warning score, as we believe it provides an even better prediction in clinical outcomes in terms of ICU admission and mortality. But I want to emphasize that CARES is not equivalent to NEWS2. First, in CARES, we identify the patient by scanning the barcode on the patient's bracelet. All the measured vital signs will be auto-captured so that we can decrease our frontline staff's workload, also minimize the chance of having human error in making the documentation. This photo shows the apparatus we used. Except O2 requirement and conscious level still need manual input to this electronic platform. Other measured parameters, including respiratory rate, SaO2, temperature, blood pressure, and pulse rate, will be automatically recorded and transferred to a medical network interface. Secondly, these vital signs will be displayed in electronic devices such as computer or iPads, and the NEWS2 score will be calculated and displayed by the system itself. And therefore, our hospital staffs can assess patients' condition wherever they go into this system. Anywhere in the hospital, such as clinic or in the operating theater, or even outside the hospital, no longer limited in the ward area. And the risk will be stratified accordingly and alert our staffs if needed. Followed by a protocol-driven action plan for those patients who are at risk. So the nurse can know when they should inform the medical staffs what should be their immediate response, what they need to do and prepare before our medical staffs come to assess our patient. And we doctors can manage our patients systematically once they arrive. This system was piloted in one of our surgical wards in the year 2019. And we compared the efficacy between the old and new systems in terms of 1. Vital signs availability, 2. Warning score availability, 3. Percentage of correct warning score, and 4. Our staff's acceptance to this new program. And here are the results. From October to December 2018, cases from the old system were randomly selected for comparison. Total 2,503 observations were recruited, while from October to December 2019, 8,382 observations were recorded in the new system. Concerning the vital signs availability, the percentage of capturing respiratory rate, temperature, and conscious level are significantly higher in the new system, with the p-value less than 0.01. As a result, not surprisingly, the availability of warning score is also significantly higher in CARES. Moreover, the percentage of correct warning score is significantly higher in CARES, likely due to the use of IT and electronic platform, so that we can minimize any human error in taking the vital signs, making documentation and calculation of the warning score. For the human factor, our staffs were asked to fill in the same questionnaire before and after the implementation of this program in 3 months, 6 months, 9 months, and 1 year time interval. Basically, this questionnaire consists of 4 domains, including the perception of ease of use, the perception of usefulness of this system, subjective norm, and also behavioral control of this system. I won't go into the details. At the very beginning, our staff's response were not so encouraging. A number of reasons for that. For example, they need to adopt a new system, a new warning score, a new routine working practice, network failure, etc. However, as time goes by, after training of staffs, repeat promotion of this program, and furnishing of our IT network system, our staff's acceptance increased throughout this program, and more staffs expressed their positive attitude through answering the questionnaire as agree and strongly agree. Finally, a few words about CARES. Early detection of clinical deterioration is crucial in patients' safety, and that's the reason why we spend so much effort in this program. Staff engagement and training is essential to implement changes. Advancement and the use of modern technology improved clinical workflows. And some people may think it is only a small step in taking the vital signs. However, this change can be a giant leap in taking care of our patients. Thank you very much.
Good afternoon, I'm Ana Tomás. I'm a nurse and I work in Centro Hospitalar Universitário Lisboa Central, Lisbon, Portugal. Me and my colleague Artur Beja are glad to present our project Follow-up Calls for Patients Diagnosed with SARS-CoV-2 led by Centro Hospitalar Lisboa Central. Here is a list of resources directly involved on this project. Centro Hospitalar Universitário Lisboa Central has its main goal to provide quality healthcare to patients. Its emergency department is classified as third-level emergency and provides assistance to trauma, burn patients, and also patients who need to be admitted into the intensive care unit with ECMO technique. Thus, we treat all patients from an expanded area estimated in 2.3 million inhabitants. In Lisbon alone, we are referenced to 49% of the population. CPU main goal is to follow up patients discharged from emergency department who require clinical reassessment in the following 72 hours. This project is based on 2 key points: medical and nursing appointment, face-to-face or by phone, and an effective, efficient transfer of the patient back to the community. In March of 2020, the SARS-CoV-2 pandemic led to the most of the population being locked down, stressing the need of safe, effective and efficient communication channels between patients and hospital caregivers. From the early stage of SARS-CoV-2 pandemic, the CPE unit dedicated most of its activity to support and follow up SARS-CoV-2 patients admitted to the emergency department and later on discharged, as well as submitting the patient's information in the National Epidemiologic Surveillance System and also in the TraceCoV trace COVID-19 application. On the first contact, a clinical evaluation is performed and medical guidelines are provided to the patient. Self-monitoring and home isolation guidelines were given according to the standards of SARS-CoV-2 patients issued by Portuguese national health authorities. CPU contact details were shared with the patients in case of their situation escalates. Follow-up calls were made by nurse staff on a daily basis until the patient is transferred to primary care entities. To respond to this project, it was necessary to adapt and quickly increase the team in order to respond effectively to the high number of patients contacted. So the team was reinforced with 12 more doctors and 3 more nurses. Taking advantage of the established clinical team and focus on a dynamic phone follow-up, the CP unit adapted itself to swiftly respond to the current pandemic, allowing the monitoring and support of thousands of patients, preventing unnecessary visits to the hospital or other healthcare units. CPU impact during this time led to reduced workload to emergency teams, early discharge from emergency department of SARS-CoV-2 patients without serious clinical criteria, faster clinical registration and infectious disease notification platforms, follow patients who were under home surveillance in self-care regime, follow patients in particular situations as patients who need social assistance or migrant communities. The hospital policy is focused on the patient and based on the safe and quality precepts. The CPU has been one of the key factors that contributed to minimize the risk of burnout of the emergency department teams, especially in peak periods, since this is a constant concern in resource management. On the other hand, in the context of SARS-CoV-2 pandemic, clinical follow-up calls provided a strong and assertive guidance to patients, stressing the necessity of following the standards of SARS-CoV-2 guidelines. And last but not the least, another significant gain was the improvement of the communication between primary and secondary healthcare, allowing the team to build a partnership with community health services that led to a win-win model for future interaction. We hope you like this presentation. Thank you.
In the coming 10 minutes or so, I'm going to share with you the value of informatic-driven process automation in the operating theater. We are smart because we get all the things interconnected. So in our anti-West cluster operating theater, the smart initiatives are actually built on the framework of the corporate clinical management system, which we call the CMS, the Centralized Anesthetic Clinical Information System, the ACIS, under which there are the OT Coordinating Center and also the Perioperative Nursing Information System. We now make use of the Rfid Tracking system to track our specimen, the equipment, and also the patients. In the preoperative setting, we have the online clinic in place, such that our nurses can follow up our patient with ease, and we can also prescribe some homework for our patients. Through the virtual surgery school, we can follow them up on the progress. They have the home monitoring for the blood pressure, the heme sticks, or even the exercise. We prescribe aerobic exercise, strengthening exercise, and also breathing exercise for our patients. Inside the operating theater, we have the 5G technology in place so that we can have instant surgical consultations through the virtual surgery system. And when the patient is in the operating theater having the operation, the relatives can access the OT status through the AI chatbot, which we call the family link. This slide shows that all these smart initiatives in place. The snapshot from the left-hand side is the family link. And under the OT Coordinating Center, we have different dashboards. Starting from here, we have the staff rostering dashboard. We have the control dashboard, which we can have an overview of the whole operating theater, and also we can send instant messenger among different locations like inter-operating rooms or from the control room to that dedicated operating room as well. We have the Rfid Tracking system dashboard, which we can see the location of our specimen and also the number of specimens being registered under the patient. When the operation is ready, we have the auto notification through the HA chat, which is an corporate instant messenger. And now we do not have to make a call to notify our surgeon anymore. Inside the operating theater, this is the 5G clinical consultation. And we also have a different interface among the system, among the module inside the system. Just like this, we have the interface between the inpatient medication order entries and also the smart drug cabinet. And these scheduled drug can also be interfaced with our perioperative nursing information system, and our nurses will get notified whenever there is scheduled drug for the patient in the operating theater. Today, we are focusing on the process automation part. So we will focus on talking about the AI chatbot, the OT Coordinating Center, and also the Rfid Tracking system. So we set for process automation in these areas because these are the pressure area which heavily relied on manual handling work, and the quality of patient care could possibly be enhanced through lean process management. First of all, we talk about the Rfid tracking system. We start off with the specimen tracking because according to our local data before the COVID status, we found that we have more than 19,000 cases, now 19,000 operations being performed annually in our anti-West cluster. And every week, we have around 150 specimens being sent out from our operating theater to the pathological laboratory. And our nurses actually spend more than 20 minutes on each specimen for tracking and also checking every day. And this inputted around 50 man-hours per week, which is equivalent to around 1.11 full-time manpower for specimen tracking. After implementation of the Rfid specimen tracking system, the specimen are being registered and their location can be easily tracked and checked under our dashboard. And there is also auto checking within the system whenever the specimens are being sent out to the laboratories. This saves quite a substantial amount of manpower inside the operating theater, and the attention can be put back to patient care. The second one is the OT Coordinating Center. The auto notification. According to our call center, actually every week we are having an average of 600 calls just for the notification of the surgeon because of the readiness of the operating theater. That means every year we are making more than 31,000 calls just for the notification purposes. The response time ranged from 1 to 8 minutes, which inferred up to around 82 man-hour per week, which is 1.86 full-time manpower just for the notification purposes. Because of this, we have worked with our IT department, and we set forth the auto notification through the corporate instant messenger system. Whenever we press on the OT readiness on our ACIS, there is an instant message sent out automatically through the HA chat to the surgeons. And now our nurses no longer need to pick up the phone and make the call through the operator, wait for their reply, and tell them operating room is now ready. The last one is the AI chatbot, which is more related to the family and also the relatives. Based on our local data again, the nursing station received up to 32 episodes of door-to-door inquiries from the family about patient status inside the operating room during a 12-hour shift. This imposed unmeasurable interruption on our nursing care because they have to reply all these door-to-door inquiries from time to time. And therefore, we have set up the Family Link, which is actually an AI inquiry platform for our patient's family. It is quite an instant update of the OT status. Also from our ACIS status, whenever the anesthetist press on the readiness, it is also, the signal is also sent to this Family Link, and the relatives can log into the system and check the status from time to time. From the time when they arrive at the operating theater to the time when they leave the operating theater and sent back to the general ward. So we believe that all these smart initiatives can work together to improve patient care by saving the time which can be saved by process automations. And now the attentions are diverted back to the patient care again. Thank you.
Hello everyone, I am Dr. C.T. Lui from the Tien Shui Wai Hospital of the Hospital Authority in Hong Kong. Today, I'm happy to share with you our EAD project. It was the digital transformation of the documentation and workflow in emergency department as a prototype of less paper hospital with discern support. We declared no conflict of interest in all teammates in our project. First of all, I would like to introduce with you about the uniqueness of the A&E service in Hong Kong. We have 18 public ED and 1 private in Hong Kong, and most of the burden lies in the public ED with more than 2 million attendants per year. And on average, there are more than 300 to 400 daily attendants in each EDs in Hong Kong. We have high throughput and burden, and we require of high operational efficiency to cater the problem. Our traditional operational workflow in ED is quite old-fashioned, with paper-based card, we call it AE card, which was all manually written, and our patient care were all based on the phone and the location of the AE card. This had a series of problems and gaps, including the problem in the quality of medical documentation, the risk of document loss, inefficient paper-based clinical workflows, and lack of real-time data to enable decision support and support the hospital management. And for the EAD project, it was a digital transformation of the ED. And our mission is to establish an e-workflow and paperless documentation to enable a smart ED. The gain of value lies on 3 parts: for the patient with better quality care, for the staff to improve the workflow efficiency and staff satisfaction. For hospital management, a lot of data can enable throughput and operational efficiency monitoring. The system covers from triage to discharge. In the triage, we have series of structural data, including the operational data, and the triage information, including the queuing information, which was also shared to public through apps, etc. It also included consultations. All the physician consultation and documentation are online. Post-consultation clinical tasks and treatment to patient discharge planning. One important point is that all the documentation now become neat and tidy, including the diagrams, and these serve for subsequent sharing with the receiving teams and wards. And one important element is the e-workflow. All the clinical requests, orders, and the clinical tasks are now online. All the requests, complete, and acknowledge of each individual tasks are closed-looped in the system. And this creates a double win of efficiency and quality. And with the specific patient list, we call it e-list, all the outstanding active tasks of each individual patient are clearly seen and followed in a real-time manner. We also have dashboard view, which was a good illustrative case of how data support the department operation. The EAD dashboard included all the information in the throughput performance in a real-time manner, including the waiting time performance. And it also included the admission panels. It enables the administrators to see where is the throughput and which specialty and the ward and the number of beds. This is an important building block for the hospital command center. So with the dashboard view, we can identify the stress zones. We can use subsequent system to further check, and then deploy our manpower and resources in the stress zone. And then we can further close loop for continuous monitoring. Not at the level of individual department and the A&E, we have a corporate dashboard view. This can show the power of the real-time operational data. All the 18 EDs in Hong Kong can be seen in a real-time manner in this dashboard view. And the data can also be used for public and patients. The timely information can be shared to the public, for example, the waiting time information through the mobile apps or web pages. We conducted an audit and impact implementation analysis in 3 dimensions, including the workflow efficiency, the patient care quality and safety, and a staff survey. In the first dimension about the workflow efficiency, we created an analysis, a breakdown analysis in the 10 time points in the ED care, and comparing the pre-EAD and the post-EAD era, we can see the triage performance remained static, but the post-consultation workflow had obvious improvement, particularly on the X-ray workflow, and the timing is much improved. And the overall A&E total process time remained closely similar. However, in the post-EAD audit, because it was conducted in the time of the COVID pandemic, we have a much longer ED stay for the COVID screening, so this is caused the problem of confounding. For the second dimension about the quality and safety care, in the first part is about patient misidentification, which is a persistent threat in the ED in Hong Kong and also other parts of the world, I think. And the EAD compared to the traditional workflow, the incident rate of patient misidentification dropped for more than half. And for more detailed breakdowns, we can see the post-consultation workflows with the problems of patient misidentification was nearly eliminated because of the closed-loop nature of the system. The second part is about the documentation integrity. We performed random sampling with the retrospective chart review and compare the pre-EAD and post-EAD era. And the incomplete and missing documentation was eliminated because the system had features to remind and have some features to alarm the doctors and the nurses if there was incomplete in documentation. And the third dimension is staff survey for acceptance. We conducted a survey in 2 hospitals by online survey, and the overall response rate was about 40%. The survey covered both doctors and nurses of all grades from senior to junior. And the major survey findings are consolidated as here. The EAD, most of the staff agreed that EAD could improve quality and safety, documentation and workflow of A&E. And gadgets to improve workflow efficiency is most welcomed by staffs. And overall grading demonstrated frontline staff preferred EAD over traditional workflow. And both junior and senior staff demonstrated similar survey results. After the EAD workflow model established in 2017 in Kingsway Hospital, under the Hospital Authority of Hong Kong, we set up a clear timeline for full rollout of this model. And by the year of 2023, and all 18 ED in Hong Kong will adopt this EAD workflow model. And for the potential of the future of the system, it created tremendous amount of structural and text clinical data, which forms the infrastructure for NLP, AI, and big data analytics. And we are now investigating for AI to support the decision of triage, sepsis, deterioration prediction, post-discharge outcome prediction. And with this smart ED workflow, it creates the prototype for the future development of the smart hospital. I here thanks for all of our team members in these projects. And this is my contact, and I welcome any queries and collaboration with you. Thank you.
At first, I would like to express my special thanks to the committees, organized committee and assigned to the committee of 41st World Hospital Congress for providing opportunities for me and my colleagues in the Child University of Medical Science for this main topic about the development of hospital intelligent management. At first, I have to describe the health system in our country, especially in our university. In Iran, has integrated health system which integrated medical education and health services. On the other hand, apart from the educational and research efforts, our hospitals and our health system are providing provisional services for the people. SPMS at present has 19 affiliated hospitals, includes 10 teaching hospitals. The HIM, that is the main topic of my lecture, is a comprehensive and integrated decision-making system for healthcare business intelligence. The performance information of hospitals is integrated and standardized from 12 databases. Comprehensiveness, accuracy, and timeliness of information is a unique feature of HIM. 70 processes and 161 sub-processes in hospitals were standardized at the first steps, and then coding of the 906,000 medicine and 82,000 medical supplies was done at the university. On the other hand, this process at present is still ongoing, and other medicine and medical cycles are integrated to the coding system in the ongoing process. All hospital information in the university headquarters was standardized and integrated into the form of a central server data warehouse at the university level. In this slide, you see 12 integrated hospital system. Previously, these 12 systems were not integrated. You look in this slide, the different systems such as a staff attendance system, patient satisfaction measurement system, performance-based payment system, and other systems that all of these 12 systems in this HIM establishment have been integrated. HIM provides decision support system. On the other hand, HIM platforms provide for us the evidence-based decision making. For example, intelligent management dashboards, standard information registration process, standard coding, integrated with the other system are the outstanding features of the HIM. You see in this slide HIM features, live data such as hospital live dashboard, bed live dashboard, patient live dashboard, and also the very important key performance indicators such as performance reports, performance portfolios, specialized dashboard. Medical records, electronic medical records such as data including information of patient records, patients record financial information packs and pictures, and also imaging system. On the other hand, insurance audit system. Insurance audit can access to medical records. Hiv strategy goals includes improving service quality, productive improvement, increasing patient satisfaction, quality improvement of clinical education. In this slide, you can see the snapshot type of the features and goals of the HIM. Live dashboards that I talked about that is functional PI have been developed in the front of 60 specialized dashboards. In this main page, the live dashboards, many information such as clinical reception, surgery, bed occupancy rate, normal empty bed, paraclinical admission, ER admission, empty emergency empty bed, stay over 24 hours. All of these data have been organized in this main page. I will describe about some examples of these live dashboards. For example, in this you can see the access to patient report anytime and from anywhere. For example, in this slide, the histopathological findings confirm the following is Lerich syndrome from one of the hospitals, and this pathological confirmation of the operation records. Another example of the live dashboards in patient live dashboards, for example, in patient admission, total empty bed occupancy rate, average radiology TAT, average time for request to delivery of medicine, all of the information have been organized in this live dashboard. And presently and currently, we can reach the many data from the live dashboards. On the other hand, another example is the live monitoring, for example, in the maternity status, the section, and also in comparison of the natural delivery and other information. On the other hand, we can see the emergency and also normal beds in the active and also the unoccupied beds. Kpi dashboards that I discussed about that. Physical resource management, including beds and medical equipment, human resource management, financial management, and 10 key performance indicator dashboards have been provided in the HIM. For example, this main page of KPI provided for us many crucial information, for example, about human resource, financial data, and all of the others. Operating room dashboard is another example of the KPI, and you can see the many information about this operating room's status in the real-time information. Emergency department dashboard is another KPI example. You can see the many data in this slide. Medical equipment dashboard will describe the many data, and also COVID-19 live dashboard. Access to epidemiological information related to the rate of infection, suspect cases, hospitalization cases, and cases after the being outbreak of the COVID-19. We provided a new sector in the for example, in this COVID-19 live dashboard, you can see many crucial information about this. Drugs and medical supplies dashboard is another vital dashboard in our HIM system. Inventory management, reorder point, inventory surplus, consumption management, forecasting, pharmaceutical strategy purchasing based on the ABC and also ATC, inter-hospital medicine and medical supplies exchange for the combating of the shortage of the medical supplies. For example, in this slide, you can see the reorder dashboard, consumption based on the ATC, for example, about 5% of drugs in our university have been consumed in the respiratory system problems. Inter-hospital exchange has been provided on the basis of the overplus and also underplus and decreasing of shortage of the drugs and medical equipments. Healthcare quality, patient satisfaction, various dimensions of the patient satisfaction in the field of 50 features of the hospital service at present are available. Clinical quality, safety-related indicators, including medical errors, nerve events, root cause analysis status, and compliance and with clinical guidelines have been considered. Clinical quality dashboard is a very important dashboard, and live information have been organized in this. Patient satisfaction dashboard is another dashboard, an example of the live dashboard. You can see the satisfaction with the physician, food satisfaction, and many of room cleanliness problems, satisfaction with nurses, and other satisfactory parameters. Balance scorecards are another features of these HISM. Balance scorecards for all physicians, specialized group, faculty members, diagnosis and treatment departments, and hospital have been provided. Scorecards are prepared systematically monthly and sent privately to the subjects. HIM mobile application of HIM dramatically increases accessibility. Users of HIM can access information needed using a mobile phone, a secure platform at any time and from anywhere. Smart automated alerts are defined in the system, which immediately inform the managers about critical events in hospital with SMS, email, and system. Many of these important events, such as maternal deaths, infant deaths, newborn deaths, medical errors. What's the outcome of HIM? Increasing patient-centered care, conducting applied research in the field of medical sciences, improving construction and development of hospitals, equitable distribution of human resources and medical equipment, management of supplies, distribution and consumption of drugs and medical supplies, centralized appointment, scheduling for outpatient clinics, improving faculty members' promotion process, improving performance of emergency operation centers, and some examples of achievement that have been extracted from this new system, established system. 25% cost saving on drugs and medical supplies, 2030 performance improvement in the operating rooms, 25% increase in clinical services, and 70% reduction in ED first. Thanks again for your attention. I will ready for your comments and your questions.
Hi, hello. My name is Ligia Kornowska, and I am deeply honored to present you our Top Disruptors in Healthcare report. It's an interview of the innovative medical startups in Poland, and it was created under auspices of Polish Hospital Federation and Young Healthcare Managers. In the area of innovation in healthcare, in particular when it comes to cooperation between startup and startup, or startup and investor, or startup and customer, there is a huge informational gap. And we wanted to address this gap. Top Disruptors in Healthcare is the only report in Poland which contains a list of Polish medical startups. The main objective of the report is to support the innovation ecosystem in healthcare, including establishing effective cooperation between startups and other entities. Our first edition of the report was created in 2020 and contained more than 70 startups. And the second edition, 2021 edition, contains about 115 startups. The Top Disruptors in Healthcare report is an initiative implemented under the honorary patronage of, among others, the Ministry of Health, National Center for Research and Development, Medical Research Agency, the National Health Fund, the Supreme Chamber of Physicians, and under the patronage of several industrial media and nearly 30 governmental and non-governmental organizations. Our commercial partners are the leading entities supporting the innovation environment in the medical sector and cooperating with startups. EIT Health, AstraZeneca, Google for Startups, and PZU Zdrowie as main partners, as well as Honeywell and law firm Domański Zakrzewski Palinka as supporting member. The report corresponds, among the other things, the question about new interesting solutions in the medical sector and their level of advancement, who and how can use these solutions, as well as what are the needs of startups and the challenges they face. Answers to questions about the current needs of startups, the solutions they offer, as well as financing and foreign expansion, enable the presentation of this information in a structured and consistent manner. First of all, the concept of a startup is unclear. So we have assumed that we will consider as a startup those initiatives whose representatives themselves consider them to be a startup. Among the potential top disruptors in healthcare described in the report, we included those startups that plan to offer or that offer services addressed to entities carrying out medical activities, service supporting medical or administrative processes which support the provision of services, services addressed to patients or for pharmaceutical companies and R&D companies related to medicine. Questionnaire for startups included several sections like financing and foreign expansion, and we found that in Poland there is approximately 380 medical startups. So our report is a review of 30% of total startup market. And now some data. 82% of startups exists as a limited liability company. Medical startups included in the report are characterized by a high level of development. As many as 90% of the startups surveyed have a product with a market value of at least minimum viable product. More than half of the responders, 53%, offer their product commercially on the market, already having their first paying customers for their main product. The vast majority of the startups surveyed already have a developed business model. And it's a surprise, but only 30% of respondents has secured a CE certificate for their product. Most respondents, more than half of them, indicate telemedicine as one of the areas of their activity. Right after telemedicine, there is artificial intelligence, machine learning, and medical data. The COVID pandemic has been affecting virtually all sectors of the global economy for the year, and the healthcare industry is no exception. But actually, our respondents indicated the positive effect of the pandemic for their business, such as the popularization of telemedicine services or a significant increase in general population's interest in health-related topics. And what is more, it is undoubtedly a positive phenomenon that during a pandemic, as many as 81 startups, so around 70%, created solutions in cooperation with hospitals. This certainly demonstrates the openness of hospitals to verify the solutions proposed by startups in the clinical environment by experts, like practitioners. When it comes to money, the largest number of medical startups in Poland obtained external financing at the level of 1 to 2 million złotych. It's around 250 or 500,000 euros. And this may be caused by the popularity of our national funding programs for innovative startups. Apart from external financing, bootstrapping is the most popular, and it was selected by 29 startups, so 25% of respondents. Up to 60% of startups generate recurring income from the sale of their main products. So we can see that, that they are quite mature on that level. Slightly more than half of the respondents are not yet presented on foreign markets, but have plans to internationalize their business. With the majority of startups planning to enter a foreign market at the MVP stage. So Polish startups are clearly aware that the domestic healthcare market is too small to be successful and are looking for opportunities to increase the range of their solutions. The top disruptors in healthcare report contains structured and relevant information on medical startups and their solutions, which allow for the conclusion of effective partnerships within healthcare sector. Our presentation was only a small glimpse into our report, but I encourage you to download it from our Polish Hospital Federation website and read all interesting data. Thank you.
Hi, good afternoon. I'm Kenny Crowell, and I'm pleased to join you to talk about AI leadership for healthcare and a curriculum and an evaluation of that curriculum to help remotely upskill the workforce to effectively manage AI. Sorry that I can't be with you in Barcelona, such a culturally rich place to be, but let me jump into it. So I want to talk briefly about why an AI leadership for healthcare professional program and why now. Then we'll talk about the program design and then some learnings from the initial cohort of the program, which was run over the past year. Just very briefly, I've served as Managing Director of CHIDS, the Center for Health Information Decision Systems, for almost 15 years, where I led a variety of health informatics programs, both with health system, commercial, as well as government partners. And only recently, about 2 months ago, I joined Accenture Federal Services to lead their healthcare analytics practice. So if we look at the healthcare AI market, we can see significant funding. And funding, as we know, is a leading indicator of where interest and excitement and things will be happening in a market. So this graph shows that in the last 4 quarters, almost $2 billion of funding was occurring in each quarter. That's very striking. If we look at another report, we see from PwC that over the next 20 years, AI is forecast to change the job market significantly, with some industries having net job creation and others having job losses. Strikingly, healthcare is projected to have the most net increase in jobs from AI with over 20% growth compared to things like manufacturing and transportation, which are seeing significant losses. Healthcare executives say that training talent and acquiring talent in AI is a top priority for their organizations. And if we look at some other recent studies, we see that some estimates point that almost 40% of tasks performed by healthcare support occupations can be automated, as well as almost a third of tasks performed by healthcare practitioners and technical occupations. That's striking as well. If we look at physicians' plans to adopt AI, we see that almost 3/4 of physicians plan to adopt AI by 2022. And these are in areas such as AI for health administration, AI for clinical applications. We also see significant growth forecast by the end of next year, things like personalized and precision medicine, as well as population health using AI. And why is this important? I mean, healthcare leaders who know how to effectively manage AI will be able to prioritize which AI projects go first, be able to create and manage a culture that can support innovation and change, and importantly, manage the risk in an AI project. There's so much hype about what AI can do. Being able to effectively discern what's real and not is critical. Being able to upskill and build competencies by staff, being able to understand where in the workflow AI can have the best and most appropriate impact, and then being a leader in this space for all reasons for understanding AI better as a healthcare leader. So let's look at the program and curriculum design for a few minutes. So the way the program was designed was to be delivered virtually for busy professionals, 4 mini courses, which I'll talk about next, four weeks per course, which is now shifting to 3 weeks. And then with every Tuesday, there being a live online session to dive into content and the AI. There's self-paced video content accompanying the live sessions with a workload of about 2 to 4 hours per week. No AI coding experience is required for this program. If we look at the target audience for this role, we're looking at hospital and practice administrators, clinicians, medical service providers, health IT and informatics professionals, as well as some of the service organizations like consultants and contractors. And insurers can also benefit from this program, but it is targeted more towards healthcare clinical services. There are 3 major areas where we believe AI can help. 1, computer vision and images. So we already see that radiology is the place in the hospital where significant AI investments are showing benefit. The use of natural language processing, or NLP, is growing. We have so much unstructured data in healthcare. I mean, the medical notes are so rich for understanding patients and trends, so being able to use AI for that is important. And then healthcare analytics using big data. Many organizations have digitized the data. Getting insights from that data is now possible with appropriate strategies. So there's a lot of information on this slide. I'm not going to go through it all in the interest of time, but this gives a picture of the 4 courses, and the program is split into 2 primary themes. So one theme being the healthcare management theme, the second theme being the AI and machine learning competencies. So the course begins with the business of healthcare, looking at payment and revenue cycles, as well as the building blocks of AI systems. I will note that the course uses what's called Google Colab, which is a software which can demonstrate the algorithms that are underlying the AI. Again, there's no coding required, but by seeing the algorithms in action, this helps promote learning. And not only see the algorithms action, but being able to tweak them through this interface. Course 2 involves service excellence and effectiveness on the healthcare management side, things like understanding your market, improving patient experience, and traditional machine learning algorithms like decision trees, clustering algorithms on the AI machine learning side. Course 3 on the healthcare management side, looking at data infrastructure and security. So much of this is happening in the cloud these days, but as well as understanding what are the standards that support these systems and cybersecurity. And then on the AI side, getting into deep learning, other types of neural networks, and how to manage those and understand them and sort of get out of that black box phenomenon that are attributed to many deep learning systems. And then finally, in the 4th course, mini course, leadership and transformation, which is so important to be able to effectively manage risk, build teams, lead organizational change. And then from the AI side, looking at how do we set up the teams to effectively launch AI, how do we interpret AI algorithms, and how do we effectively develop ROI and calculate that ROI from AI programs. So in our first cohort, we have 14 individuals, primarily from health systems, with 8 from health systems, 4 consultants, and 4 from other organizations like academic and the government sector. And this is a mix between both clinicians as well as managers and directors from information systems departments. And we surveyed them across the course, and we found on a 5-point Likert that people really do find this content valuable. And importantly, they also found they can apply the learnings to their job. And we're also curious whether the Google Colab was an effective tool, and it looks, by their responses, it looks like it was. Now, we also asked what things did they suggest changing. So things like more time for breakout groups. Within the class, we got the group, we made small groups to let people explore these topics and explore strategies, but they needed more time for that. People asked for more time for reinforcement learnings through activities, also to keep sessions at time. And we structured the course with the healthcare management and the AI system, and doing all that in one night on Tuesday was sometimes a lot. People also requested more collabs to dig into specific use cases and additional readings. So looking ahead to the next cohort, we're going to embed some of these findings. We're going to move it from a 16-week program to 12 weeks. So each of the 4 mini courses go from 4 weeks to 3 weeks. We're going to have a greater focus on problem solving with AI. Now, we did tackle some problems, but I think we want to take some more specific use cases to our specific learners and show how to tackle that with AI. Additional group work with more time to debate and explore, and then continue expanding cases that can be rapidly adopted and applied in a healthcare organization. So this was a quick, short presentation just to give you an overview of an important way to meet an upskill need for healthcare managers regarding AI. There's so much happening right now in adopting these systems, and leaders need to know how to manage them. And here's some contact information. My colleagues at the University of Maryland, as I said, I'm now at Accenture Federal Services today, more than happy to talk to you about the program. So with that, I think we have a few minutes for some questions, and I'd be happy to take those now. Thank you.